How was everybody this morning? Did you have a good day at Rapid yesterday? Yeah, good. That's awesome. For those of you who have not seen me up here yet, my name is Debbie Holton. I'm the Director of Events and Industry Strategy for SME, and we're just so pleased that you've joined us here in Orlando for Rapid. This event has been so dynamic and exciting. New products, new technologies, new companies entering the space, and there's still more to come today. Additive manufacturing and 3D printing are transformational, game-changing technologies, not just changing the way we make things, but changing lives as well. So many life-saving innovations in medical and other industries are made possible every day through 3D manufacturing. And Rapid is the place where you are sitting on the front row of the industry news and events. You are the witness to disruptive technology and innovation seen nowhere else but here. And today, we'll learn about innovation that contributed to the first lives saved with 3D printed medical devices and the doctors who printed a second chance. So let's get underway. I know you're all here to hear these wonderful developments in technology. And first, I would really like to thank our sponsor, Materialize. And we're going to play a short video.
3D printing has evolved into a true industrial manufacturing technique, adopted by an ever-growing and wide range of industries. But have you ever wondered about the technology behind these innovations? Can you imagine how designs for 3D printing develop? How they're made printable? And how you make sure you only build parts that fully meet your expectations? How you can scale up your production? And how all of this can meet your industry standards. For over 25 years, we've been building the software backbone for all businesses and industries that want to apply 3D printing in a professional manner. We've become the trusted partner of leading machine manufacturers. We've co-created platforms that are the engine of disruptive innovations that change the rules of businesses, that change how factories run, and have an impact on people's lives. And we keep pushing the boundaries of 3D printing because we believe that extraordinary technologies need extraordinary software.
Thank you, Materialize. We appreciate your support in this session this morning. And at Materialize, their motto is innovators you can count on. So it's with great honor that I'm here to introduce you to the founding innovator and CEO of Materialize, Wilfried, or Fried as he is known, von Kron. Fried discovered the groundbreaking, innovating technology we all know as 3D printing while he was working as a research engineer and consultant at the Research Institute of the Belgian metalworking industry. Passionate about this new technology and firm in his belief that it could help to create a better and healthier world, Fried founded Materialize in July 1990. And since then, he's worked to build a software backbone for 3D printing. Fried holds several patents related to the technical and medical applications of 3D printing and has received numerous awards and honors, including SME's Additive Manufacturing Industry Achievement Award, TCT Magazine's Most Influential Person in Additive Manufacturing, one of the top leading players in 3D printing by the Financial Times, and the 2013 Visionaries Award from the Museum of Art and Design in New York. I was fortunate enough to actually be there to see Fried receive the award from the museum in New York, and I have to tell you that he is just so incredibly respected by the entire design and art community as well as our manufacturing community. Fried remains committed to using 3D printing to make positive changes in people's lives. Please help me welcome Fried von Kron.
Thank you, Debbie. I'm very pleased to be here today. This is a wonderful event that has been put together by SME, and Materialize is proud to support it. When I bought my first machine more than 25 years ago, I was excited by the amazing possibilities of this technology and how it could help to create a better and a healthier world, as indicated before. But I also personally experienced from the very first product I wanted to get out of the machine the challenges of 3D printing and wanted to help others by providing software solutions that would generate that people could manage their machines more effectively. Today, we are proud to be part of this great community here today. And we are proud to be offering them an entire range of software and services which together form a kind of backbone of the 3D printing industry. Our software, like the Materialize Magix 3D Print Suite, offers an open and flexible solution to players in a variety of industries that are using 3D printing for innovative applications. Our solutions are open by nature, empowering co-creation and collaboration between different players in the 3D printing and manufacturing ecosystem. But we are also committed to building evidence to support medical 3D printing. More institutions like the University of Michigan can help to create this better and healthier world. This work is far from a piece of cake or as easy as pressing a button or whatever simplistic marketing messages want to make you believe. Every truly meaningful application is the result of many years of intense effort and collaboration between medical specialists, material specialists, software specialists, mechanical designers, machine specialists, a process of trial and error that spans multiple years, or for some applications, already decades. It has been an honor to work with the team of University of Michigan for so many years. They are using our software for solutions that truly show a big impact on patients and that make the lives of individuals truly much better. I'm excited to be part of this life-changing technology and can't wait to see what the future holds. Now, it's my privilege to introduce the keynote speakers this morning. Those two individuals share our same passion for helping changing lives, and they are also truly innovators. Dr. Scott Hollister is a professor of biomechanical engineering and mechanical engineering at the University of Michigan, where he directs the Scaffold Tissue Engineering Group. Dr. Hollister and his collaborators have designed and developed a variety of medical devices utilizing 3D printing, an area in which he has worked for already 17 years. His general research focuses on design, fabrication, and evaluation of biomaterial platform systems for tissue reconstruction. Dr. Robert Morrison joined the University of Michigan in 2011, where he is completing his residency in Otolaryngology, head and neck surgery. His research on personalized medical device development using additive manufacturing has been featured internationally in the lay press and in several journals, including the Science Translational Medicine and Pediatric Journal. Dr. Morrison has a particular interest in 3D printing applications in the head and neck, airway physiology, and reconstruction. Without further ado, our partners and amazing innovators, Dr. Scott Hollister and Robert Morrison.
I'm going to grab a water. I'm an ear, nose, and throat doctor, so I got to hydrate the larynx. I want to thank SME for the opportunity to come here and talk today. I'm Robert Morrison. I am a chief resident in otolaryngology, head and neck surgery at the University of Michigan. As part of my training, I spent a T32 supported year in Dr. Hollister's lab, looking specifically at additive manufacturing applications and medical device development. Dr. Hollister, that was a wonderful introduction for him. He's a professor of biomedical engineering at the University of Michigan. I also want to thank Materialize for sponsoring this session and also for their support of our work. Without further ado, for disclosures, Dr. Hollister has filed a patent related to the device that we will be presenting today. The University of Michigan has entered into an exclusive licensing arrangement with Materialize to support taking the device through a phase 1 clinical trial, and we can't thank them enough for the support, for being willing to support a medical device for a rare medical condition. And I have no disclosures. I want to talk a little bit about the condition that we were setting out to find a treatment solution for. The condition's name is tracheobronchomalacia. Here's a few excerpts from a few parents of children with the disease. Nicole Lynn once said she could stop breathing at any moment. Every cough, every sniffle scares us. Christy said, it's hard and exhausting laying in your bed, needing sleep, wanting sleep, but you're too scared to go to sleep because you can't hear your child if you stop breathing while you were asleep. Law said, in an instant, the mood can go from hilarious and joyful to panic. He looks at me with a panicked look in his face like, Mommy, help me. But all I can do is wait for him to calm down. It's horrible to have to keep your child from laughing. And I think Amanda Strickland had the most insightful comment when we were initially starting out to treat this condition. She said, when your child wakes up in the middle of the night, red-faced, gasping for breath and coughing, tears streaming down his face, as a parent, you just want to fix it. But to know there is nothing I can do to truly fix it makes my heart ache. So tracheobronchomalacia is a disease, we call it floppy airway disease. It's a disease of inadequate structural support of the primary airways. It affects about 1 in 2,000 infants. So it's a fairly rare disorder, but in a major medical center, we see it not uncommonly. In the infantile form of the disease, it's often self-limited, and most infants will outgrow the disease within 2 to 4 years. But during the initial 2 to 4 years, they're often very, very sick. It can either be a problem of inadequate structural integrity of the cartilage of the airway, or it can be a problem where there's something outside the airway that is compressing it or squishing it. The primary problem is that there's obstruction of the airway on expiration, so the child can breathe into the lung but can't expire air from the lung, and this results in trapping of air in the lungs, inability to oxygenate or to blow off CO2. The more severe forms of this disease result in cardiopulmonary arrest or CODES. Wrong button. Here's a video of one of the children that we treated with tracheobronchomalacia. Here we're looking down the airway with a camera, and this is the trachea and where it splits into the 2 bronchi that go to the right or left lung. And as you can see, it almost looks like someone's pinching the airway shut with their fingers, and you can't see a lumen or a black area in the middle down into the lung. The gold standard for treatment for these children is placing a tracheostomy tube or a breathing tube in through the neck and putting them on a ventilator with positive pressure. And the positive pressure functions like a pneumatic stent to keep that area of the airway open. There are some rare children that have a defect that is favorable for surgical correction, but those are pretty rare. And there has been some experimentation of placing stents or inside the lumen of the airway. But with children that are, one, quite small to begin with and growing rapidly, that often is fraught with complications because there could be mucus plugging of the stents, migration of the stents, and you often have to resize them frequently. So all treatments have a very high associated morbidity and mortality, and even despite the best treatments we have available, select children remain critically ill despite those treatments. And so these are the children that Amanda was talking about when she said there is nothing that we can do. So in some ways, this disease seemed very favorable for a 3D printing or additive manufacturing approach. All different areas of the airway can be affected. We're talking about children with very small anatomy. And so having a device that you can customize to that defect is kind of a solid approach. And there's been a lot of interesting and promising applications in medicine, from preoperative surgical planning to tissue engineering applications to even 3D printing medical implants. But what we ran into when we were looking to create a device for this disease is creating a device for a patient that's this size that's eventually going to become this size. So what we know with human growth, Galileo first commented on the way humans grow in two new sciences in 1638. But human anatomic structures obey the cube-square law with growth, which means that the volume of the structure increases faster than the area. And most anatomic structures in infants will scale to 10 or 20 times their size as they grow into adults. Related to the disease we were looking to treat of the trachea and the bronchi, a fixed implant on the outside can restrict growth of the airway and fight against that natural resolution of disease that occurs as children grow. And as I talked about, fixed intraluminal devices are often small and they will plug with secretions, or they will migrate and require frequent resizing procedures. So we needed a device that changes with the patient as they grow, so that there was no need to resize the device multiple times as the children grew, and there was no external restriction of airway growth after the device had been implanted. We needed a device that resorbed so that it didn't have to be retrieved as the child got older, and we needed a device that was specific to the patient defect, since this malacia can occur anywhere along the tracheobronchial complex. So what is 4D printing? There's not really an exact definition that's been delineated or agreed upon at this point. When we were setting out to create a device that changed, this was the definition that we came up with, and it was based on a commentary that Dr. Tibbetts had published in 2014, but we defined 4D printing as any additively manufactured object which exhibits engineered shape change owing to design and material influence deformation in response to a specific stimulus. This is a nice review that was put out this year in the International Journal of Bioprinting, talking about the different ways that creators have harnessed 4D printing. And there's three different ways that have been described to date. One is where you 3D print cells or a tissue engineering substrate along with a manufacturing substrate. You exhibit a stimulus, and theirs, it was an electrical current that induced deformation of the mechanical substrate to fold the tissue engineering substrate into a favorable conformation. Other groups have looked at microspheres or biospheres with cells embedded in them that, when are exhibited to a stimulus like heat, will self-organize into a desired conformation. But what we're really going to be talking about is the middle column here, which is where you have a medical device with biomechanical properties that are designed to accommodate a specific tissue stimulus. In ours, it was the force exerted by a growing airway that allows growth of the structure while still treating an underlying disorder. And so now Dr. Hollister is going to talk a little bit about how we went about setting the framework for that device design. There you go.
Yeah, so these requirements for the splint, the fact that it has to protect the airway from compression of surrounding anatomic structures, that it has to allow these structures to grow as the child grows, and in addition to that, we'd like the material to be resorbable so you don't have to do a second surgery, presents some really significant engineering challenges. So in setting this out and trying to think about, design control measures and things like that, we set 6 specific design targets for the splint. One was, of course, it had to resist the external compression of the other anatomic structures that led to the malacia in the first place. Secondly, because it's going to be in the head and neck, we wanted to have some flexibility in bending to accommodate motion of the child. Thirdly, of course, we have to allow radial expansion because, as Bobby mentioned, that the airway is going to grow and the splint has to accommodate that. Another important challenge is the fact that, as Dr. Morrison mentioned, these children come in various sizes and shapes, and the length of the malaysic segment varies between childs, so we have to be able to customize the splint for different anatomies and different defects. It has to be bioresorbable, and of course, because we're implanting it, it has to be biocompatible. So this is the prototype we came up with. The additional thing that you see here is we also have to have these holes periodically distributed through the splint, because that's what allows the surgeons to suture the outer wall of the splint, or sorry, the outer wall of the airway into the splint. So if you think about it as an analogy of a tent, you can think about the airway as a collapsed tent on the ground. You can think about the splint as the tent poles, and then the sutures are basically the ropes you loop through the tent and pull through the tent poles to open up the airway, and that's why we have the suture holes periodically placed through the splint. We made it a bellow design to allow some flexibility in bending. Obviously, it has to have an opening so the surgeon can place the splint around the airway, but the opening also serves as the enabling geometric feature to allow growth of the airway of the child over time. So this is conceptually how the splint works for a collapsed airway. You can see on the left, due to exhalation pressure and the compression of the surrounding structures, the malaysic airway, as Dr. Morrison had shown, will collapse when the child breathes out. So the idea is, if you have the splint as the white ring there, that basically you can run sutures through the outer wall of the airway and then tie those sutures into the splint, and that structural splint will then hold the airway open and resist both the compressive forces of the surrounding anatomic structure as well as the negative pressure when you exhale air from your lungs. So again, we're looking, we'll go through these, I'll go through these one by one to show you how we try to incorporate this into the design of the splint, as well as how we evaluate the splint performance. And so when you think about resisting external compression, all of these in fact are really a combination of design and material, but especially the customizable variable anatomy is a difficult thing, and that's where our work with Materialize and the Mimic software has been critical, in that we can generate digital models of the patient's airway, we can measure the malaysic segments, and we can input that data into our own software that we wrote to generate the design of the splint. And then the other unique thing we're doing is that we're actually making the splint from a biomaterial called polycaprolactone. That's a material that has been approved by the FDA for within some indications, some applications. The nice thing about PCL for this application, it's a very slowly resorbing material, and we need the splint to be around for about 2 years as the child grows, and then the airway becomes large enough so the risk of complete collapse is greatly reduced. And then we actually, after that period, the material will be resorbed and essentially excreted from the body. So I'm going to talk a little bit about the design characteristics and how we came up with the design targets. For compressive support, we try to look in the literature. There's actually not a lot of data. There are probably maybe 10 papers total on the mechanical properties of airways in general, and a lot of these are, as you'd imagine, for older people, because those are most of the cadavers we get for testing. So they may not be relevant to the children's airway. So we looked at younger animals, in this case pig tracheas, and we found that under a 20 Newton load, that would cause about 50% of compression of the airway. So that's the maximum compression of the airway we want to allow. And so our target for designing for compressive support is that if we expect the splint to be placed under 50 newtons of load, it should deform less than 50%. In terms of bending, we also took design targets from this paper and said that under a 20 Newton 3-point bending load, that the splint should be able to deform between about 20% to allow flexibility, but not greater than 50%, which would risk pinching off the airway. Radial growth is a much more difficult thing to quantify, as you can imagine. Trying to determine how much the airway grows over time, let alone how much force a growing airway would exert on a structure sutured around it. It turned out there was a paper out of the United Kingdom in 1981 where otolaryngologists looked at growth of airways in kids who had normal airways as well as airways with tracheostomy. And from their data, they found that the maximum growth of the trachea was about 20%, as you see here. So we took that as a criteria. We tried to develop or estimate a force that a growing airway would have to overcome to actually grow. And the airway is surrounded by many large arteries, especially the aorta. And based on aortic pressure, we came up with a resistant force to growth of about 15 newtons. So based on all of these rationales, we said that under a 15 Newton internal pressure, the splint itself should be able to expand by at least 20% to allow what we think will be normal growth of the child's airway. So of course, we do a lot of both simulation and testing of the splints to make sure they meet these targets. In terms of the compressive stiffness and strength, we do compressive testing, which is very similar to ASTM guidelines for testing stents, for arterial stents. And then for flexibility, we do 3-point bending as per ASTM F2606. But for opening and growth, there was no test out there, no ASTM standard to test the airway for growth. So we came up with this idea of saying we're going to mimic that by pulling the splint apart, and we went to Home Depot and got some picture hangers and stuck those in our testing machine, and we used those to actually pull the splint apart so we can get actually what we call an opening stiffness to ensure that under a 15 Newton load that the airway splint will indeed expand by at least 20%. We also do simulation. We want to simulate how the splint affects the patency of the airway. So we first developed a nonlinear model of the airway. The biological tissues have very complicated mechanical properties. Typically, they're hyperelastic, viscoelastic. And we can reproduce actually airway collapse in the model because your airway is basically made of periodically spaced cartilage rings. Those are the stiff parts of the airway. And if you reduce the properties of those stiff rings, you can see that the airway actually become unstable and collapse. The nice thing is we then generate the STL file that, of course, we use for both input to the manufacturing machine, but we use that as a basis for meshing, and again, we use Materialize for this. So from the design that we generate from our program, we input that into 3Matics actually, and we mesh it, and then we import the splint directly into the digital model of the patient's airway. We simulate the sutures as nonlinear springs, and you can see that under exhalation that the splint in the simulation can actually resist collapse of the airway. You're actually going to see that we're simulating growth of the airway within the splint, and this is a splint we've designed to meet those target stiffness. And you can see based on our estimate of growth that as the airway grows, it will actually push the splint apart. So that's how we address the first three of our target goals for the design of the splint: to resist compression, protect the airway, but at the same time, as the airway starts to recover and remodel, to allow that airway to grow. The fourth requirement that we have to meet is being able to customize the splint for the variation in anatomy. And this is really where the combination of software, like the Mimic software, and 3D printing play a critical role, because obviously we're going to need to maybe produce lots of these for a specific child, only one at a time or perhaps two, so we have to be able to customize it for the airway. Because again, the nature of these defects can vary. As we'll see, some children will have bilateral defects, some will have unilateral defects. They have different lengths and they have different diameters. So to do this, we actually go, and this is an example of using mimics, we go in and we segment the lumen of the airway, and from that lumen and on a CT scan of the child under exhalation, we can actually figure out the length of the malasic defect, and then we assume a certain wall size for the airway wall because we can't see that on CT, and based on the lumen size plus the wall size, we can get an idea of the diameter the splint needs to be. We can make the design in the software, and then we can import the design for the splint back into Mimics and make sure that it actually fits the child's anatomy before they're even taken into surgery or the splint is manufactured. So this gives us patient specificity. We can design and build the splint directly for an individual patient and size it to their specific airway. And this just shows an example of the first 3 children that received the splint. You can see that the airway is shown in brown. That's created from the digital model of the patient. And then we import the design splint into the airway model and make sure that it fits on the airway. And Garrett Peterson, who you'll meet later, the second patient actually had bilateral splints. Of course, now that we have this device and it has some complexity, it's patient specific as per the new FDA guidance document on additive manufacturing. It has to be resorbable, it's bellowed, it has periodically placed suture holes, and we want it to be built from a bioresorbable material. To do this, we actually developed a technique to do laser sintering of polycaprolactone in an EOS P100 machine, and we have that material cryogenically milled to 40 to 60 micron particle size, and then using this technique we can actually build about 200 splints in a single build. So this just actually shows the polycaprolactone fabrication in process in the laser sintering machine, and then it's actually recovery of the splints from the powder cake for use. Unfortunately, it doesn't go that fast in real life. It's a bit slower. Then, of course, beyond this, we have to be very careful to clean the part. I mean, this is a big thing with medical devices. Again, it's come out in the guidance document. We sonicate it in sterile 70% ethanol, and then we actually send the splint out to a third party to be EO sterilized for implantation. And so that's basically how we go through the engineering, design, and manufacturing and sterilization of the splint. And Dr. Morrison will give you the rest of the talk on the clinical use.
Thank you, Dr. Hollister. So I'm going to talk about our opportunity to use this design and manufacturing technique to treat 3 children who had life-threatening tracheobronchomalacia. Our first child underwent implantation back in 2012. He was transferred to the University of Michigan at 3 months of life. He'd been in the ICU since the first month of life, and despite being on a mechanical ventilator with a tracheostomy tube, he was not able to ventilate well. His CO2 in his bloodstream was 80, which was significantly elevated, and he was on essentially maximal positive pressure ventilation settings on the ventilator. In addition, he required intermittent paralysis just so that they can maintain his ventilation on the ventilator, and he had repeated code events despite being on the ventilator. And here you can see the preoperative CT scan and mimics model of his defect. It was the left main stem bronchus that had tracheobronchomalacia, and this was due to an abnormal anatomy of his pulmonary arteries and his aorta that was pressing on the airway at that location. Our second patient, Garrett, he underwent implantation in January of 2014. He was transferred to us at 16 months of life. He had been hospitalized his entire life and had been in the ICU for a long period of time before they were transferred to the University of Michigan. He required paralysis just to maintain enough breath support on the ventilator to keep him from having code events. But despite that, any sort of manipulation resulted in life-threatening desaturations. Here you can see his preoperative CT scan and our mimics model of his defect. He had bilateral mainstem bronchomalacia due to tetralogy of Fallot, which is a congenital heart condition that resulted in a significantly dilated pulmonary arterial system, and that dilated pulmonary artery was basically squishing both of his bronchi. Our third patient, Ian, underwent implantation in May of 2014. He was transferred to us at 5 months of life. He had been on cardiopulmonary bypass shortly after birth, and then had some cardiac procedures, but after his cardiac conditions were addressed, he was still having life-threatening events on the mechanical ventilator. At one point at the University of Michigan, they could not find a ventilator in the hospital that could successfully ventilate him, so an ICU nurse had to hand bag ventilate him for over 8 hours the night before his operation. And here you can see the preoperative CT and the mimics model of his defect. He also had a left mainstem bronchus malacia that was due to a similar defect as our second patient. He had that tetralogy of Fallot. As far as regulatory approval, we submitted our device for humanitarian use device designation, and that was granted by the OOPD in 2012. This was based on some preclinical data we had done in a pig model. All 3 patients were individually approved to receive the device, both by our institutional IRB and the FDA under the emergency use exemption. The pathway we're currently pursuing for approval for our device is the humanitarian device exemption pathway, which is very similar to a PMA pathway. And we have a paper out, here's the reference for it, where we talk about some of the regulatory considerations of our device, if you would like to read further. Here's the intraoperative pictures of all 3 patients. That's Kaiba on the left there, and Garrett in the middle, and then Ian on the right. One of the advantages of doing all of our device design on the computer is that you can rapidly adapt your device design. So for Garrett's case there in the middle, since he had to receive splints on both of his bronchi, if you just put a standard C shape onto each of the bronchi, as you can imagine, they would overlap in the middle right there where the airway splits. And so we incorporated a spiral design into his left splint so that the open face of the spiral would accommodate the right bronchus splint. That was something we talked about in our preoperative design meeting, and Dr. Hollister had a design by the next day. So it just really shows how rapidly you can customize these devices to the patient's need. Here's, once again, some airway endoscopy of 2 of our patients. This is Garrett's preoperative bronchoscopy, where we're looking down the windpipe with a flexible camera. There's the right mainstem bronchus and the left, and as you can see, they look like they're pinched off, and that's because of the enlarged pulmonary artery that is pressing on his bronchi. This is the same examination that we did immediately after the splints were placed. Pardon us while we suction a little bit of blood here. Whenever there's airway surgery, there's always swelling and blood. But what you'll see in a moment here is now when you look, you can see a dark area, and that's a kind of pathway now for air to enter into the right lung. This is Ian's preoperative bronchoscopy as well. If you look on the left side or the right side of the screen for us, that right bronchus looks like it's pinched off. You can't see any black in the middle of it because the bronchus is completely collapsed. And then here we have our bronchoscopy that was done immediately after implantation of the stent. And you can see a black area in the middle of the airway now. That's now that the left bronchus is now open and allowing air to get into the left lung. Our first patient, Kaiba, initially we attempted an aortopexy, which is a standard surgical procedure to treat his defect. And after the aortopexy, we noticed no improvement in his condition, so he received a splint on the left bronchus. Within a month after surgery, he was off of the mechanical ventilator completely, and he was home for the first time since 1 month of age within 6 weeks after surgery. He's now over 4 years out from implantation of the splint, and he's been growing and developing normally. He's had no readmissions to the hospital and no complications related to the splint implantation. We do have an MRI from about 3 years after surgery that is showing that the splint is beginning to degrade, and I'll show you those images in a moment. Garrett, who was definitely our sickest child, failed an initial pulmonary artery mobilization, and so he received splints on both of his airways. As I talked about before, you can see the left splint has a spiral design to it, and that's allowing the left splint to accommodate the physical presence of the right splint. Pretty much immediately after placing the splint, we noticed that the left lung was beginning to be ventilated. It was very distended at first, and it was pale, and then it turned pink as soon as the splint was placed. Within 4 weeks, he was stable enough that he could be transitioned to a portable ventilator, which was a very key point in his recovery because that meant that he could finally go home. And he was discharged home for the first time in his life at 17 months of age, about 6 weeks after the surgery. And he's now off of the ventilator. Another interesting thing about Garrett is that he had a medical condition called protein-losing enteropathy, which is where the gut becomes very swollen and it's unable to absorb proteins or nutrition. It's very rarely seen in children with tracheobronchomalacia. What we think is that when we give those high airway pressures to ventilate the lungs, that compresses the portal venous system and it causes the gut to become distended. And Garrett had a very severe form of it. And after we placed the splints, his PLE went away. Ian also failed aortopexy and he received a splint on the left side. Ian was a little bit different in that he also had malacia far out into his left lung in areas that we couldn't successfully put a splint on. As you can imagine, as the airway branches, things get smaller and smaller and they get farther and farther out into the lungs. And so once you get past the primary airways, you really just can't get out and place a splint any further out than that. So for him, our goal was not to get him off the ventilator, but just to get him stable enough that he's no longer having cardiopulmonary arrests. And immediately after the splint was placed, he no longer had any life-threatening events or arrests. He was discharged home 6 weeks after surgery, still on a ventilator, but on a very minimal amount of positive pressure ventilation. And there have been no complications related to his device as well. Here's the ventilator requirements of all 3 of our patients. The gray arrow is the point where the splint was placed. And as you can see, the pressure requirements on the ventilator drop dramatically and significantly immediately after surgery. And you can even see on Kaiba, which is the top graph, where we were able to discontinue the ventilator within 4 weeks after surgery. Looking at Garrett, which is very interesting, here's some run control graphs. The top one is the pressure requirements on his mechanical ventilator. The middle one is his albumin, which is how much protein there is in his blood. And in kids with protein-losing enteropathy, they have a very low albumin because they're losing all that protein through the gut because it's so swollen. The green area of the graph is the normal range. And then the bottom is his serum immunoglobulins. It's the same phenomenon as albumin, but immunoglobulins get lost through the gut in kids with PLE. And as you can see, it's almost a direct correlation where as we come down on the pressure requirements on the ventilator, his albumin and his immunoglobulins come back up into the normal range. Here's some CT scans of all 3 of our patients, both preoperatively and postoperatively. The black arrows on each scan denote where the malacia was located. And as you can see on the preoperative scans, that area is gray because it's completely collapsed during expiration. And when you look on the postoperative scans, you can see that the area is now patent on expiration, which is the goal of the device performance. Here's our airway growth data to show how the device allows for airway growth. Unfortunately, you can't see the splint well enough on any imaging study to create a model of the splint after it's been implanted, but we use airway growth as a surrogate for splint performance. For Ian and for Kaiba, as you can imagine, one airway got a splint, the other didn't. So it was nice. We had a control within the same patient for looking at normal airway growth. And in Kaiba, who we have our longest term airway growth data, now up to 4 years, you can see that the splinted bronchus, which is the black line, is growing almost on the exact same trajectory as the normal bronchus. Garrett, who received bilateral splints, we don't have a control for him, but we are seeing ongoing airway growth in both of his bronchi. And then when we look at MRI imaging, we have to use a special MRI sequence. It's a turbo spin sequence to look for the splint. But the white arrow denotes where the splint is located. The white on the MRI is the soft tissue within the mediastinum. The black circle in the middle is his left bronchus, and then that kind of dark crescent around the bronchus is the splint. And where you see the black asterisk is actually evidence that the splint has started to fracture and degrade. This was at 3 years after surgery, which is about the time that we would expect the splint to degrade. A lot of the technical data from this talk is in our science paper. Here's the reference for that. But what I really want to emphasize is beyond all the numbers and the science is the patients. And most importantly, all 3 of these patients are now home with their families, and they're growing and developing. Beyond those specific applications, we now have a 4th patient that we've placed a splint into who's now 8 months out and is doing well as well. As I mentioned at the beginning, we have a phase 1 clinical trial that's forthcoming soon. And we're also looking at expanded applications for the device. So beyond the children that are so sick that no treatment works, looking at can you put a splint in a child to avoid having to do a tracheostomy and to send a child home on a ventilator for 3 years. We've also looked at permanent splints for adult applications for patients that aren't going to outgrow their disease, and we're looking at tissue engineering applications. As far as adult applications, we recently had an adolescent with a very unusual situation. She had very severe scoliosis, so her spine was continuing to flex forward, and her trachea was getting squished between her breastbone and her spine. They'd done a variety of different surgeries to try to correct this, but couldn't get her off of the ventilator. Because she's an adolescent, we were not expecting the problem to go away with growth, so we were looking at a permanent option, and in this case we printed a splint using polyethyl ketone, that's OxPEC, which is a material available through Oxford Performance Materials. These are our pre- and post-operative images for the patient. Her name is Hannah, which show that the splint immediately increased the diameter of the airway at that site. And Hannah's now back to school in Texas and has had no further issues, and she's over a year out from surgery as well. So I guess just to summarize, I don't want to give the sense that this is the only way to approach medical device development for growth. 4D printing can encompass a variety of different processes, but I think they all encapsulate designing a device that exhibits engineered conformational change in response to a specific stimulus. And clever device design and biomaterial selection can result in medical devices that change with patient growth, but I think the most important point is the work that you do up front and the work that Dr. Hollister talked about, thinking about what's the condition that you're treating, what are the performance criteria that you are developing, and setting those up very mindfully in the beginning is going to set you up for success further down the road. And I really want to emphasize that we're only beginning to scratch the surface here of the potential for additive manufacturing in medicine. I truly believe that there's a plethora of creative protein medical devices that harness this technology that are going to be coming out in the near future, and ideal applications in patients with life-threatening but rare disorders. Special thanks to the Mishra-MyApp group, which is our regulatory support group at the University of Michigan, and OPM, who supported us with Hannah Splint. Our work is supported by an R21 grant, and my work has been supported by an institutional T32 grant. Here's our lab group outside of our Lurie Biomedical Engineering Center in Ann Arbor. And now I'd like to take a special opportunity to introduce one of our families. Jake and Natalie Peterson are from Utah, and Garrett was our second child to ever receive the device. Garrett had been stuck in the hospital for 16 months and had been unable to really even consider going home. And I remember Natalie telling me a story about how they were in the ICU at the University of Utah, and one of the ICU nurses left our New England paper on their bedside table about a child that had received a splint for tracheobronchomalacia. And they called us, and Dr. Green, who is our pediatric otolaryngologist, called them back the same day. And it took a couple of months to get him over to the University of Michigan. He had to be transported on an ICU plane. And I really respect the courage it must take in that sort of situation where you have a child that you feel like you can't do anything for, but there's a risk, a leap that you have to take to hop on a plane, move halfway across the country, stay there for as long as is needed. You don't have a timeline. You don't know how long you're going to be there. You don't know if this is going to work. It's only been used once before, just the true courage that it takes in that sort of situation. And so we actually have Jake Peterson on Skype today, and he's going to speak for a few minutes and give his kind of thoughts and reflections on their experience.
Hello, everyone. We so excited to see Dr. Hollister, Dr. Morrison. They're both incredible, and were so integral to Garrett's recovery, and they're so amazing. We also, haven't had the chance to thank everyone that was involved with helping Garrett. So SME, Materialize, you are all incredible. All of you have been involved in this. I know it's taken years of research and development and so many people, but you're all the reason that Garrett's here with us today.
Like you both have said, Garrett was born with a really severe case of tetralogy of flow with absent pulmonary valve, and so severe that he was stuck on a hospital ventilator and wasn't able to come home with us, which was so hard. It was so hard to leave our little boy every night in the hospital and not having anything that could help him here in Utah. And that was really hard for us.
Yeah, we always remained hopeful that we'd be able to find something that would help Garrett. And as Dr. Morrison said, we were able to find an article that was given to us by one of the respiratory therapists at the University of Utah. And we were able to get in contact with Dr. Green and the team at University of Michigan. And it's just been so amazing, because we were told he'd likely spend his life on a ventilator because of how severe he was. He'd have to be in a medical facility his whole life, never at home, and his quality of life would be very poor, And so it was hard, but it was incredible how quickly he's recovered and how well he's doing now. The 3D printing, I think, was incredible and absolutely necessary for Garrett to be able to recover like he has, and to be able to customize the splints so they fit his airways perfectly.
Yes, and he, as you can see, he's an active little boy. He's such a happy boy, and he loves Mickey Mouse. He's like everything Mickey Mouse Clubhouse. And I think one thing that we definitely don't take anything for granted. Not even the little things. Just being able to go for a walk around our neighborhood, or going over to our family's houses for dinners, and we've actually been able to celebrate 2 Christmases at home now, which has been amazing. And Garrett is continually getting better. He no longer needs his ventilator during the day, and he can be free from all the tubes and things. He actually is completely off oxygen needs also. So he just wears this little nose piece, and he can go about his day. He's almost sitting up on his own, and he has a little walker that he uses and walks around our house, and he's doing really, really well, and we are so grateful.
Yeah, he's super, super fun. He's rolling around our family room like all day, all the time, and you leave the room for a couple minutes, and he's starting to do like very normal 3-year-old things, like we'll leave, and all of a sudden he gets into like a little box that has like these chapsticks in it, and we come back and he's got Twizzler flavored chapstick all over his face, and looks like he didn't do it, someone did that to him. He's looking around, and so it's fun to see him do all these normal things that we at one point never thought were possible. But we this whole process couldn't have gone better for us. The 3D and 4D aspect, I think, is the most impressive. The fact that Garrett can have these splints and that they let his airways grow and adapt has been incredible. Garrett has never had any hiccup of any type of complication with his breathing since he's had the splints placed, and just continues to defy all expectations, and he's just doing incredible. And his long-term outlook, doctors are thinking there's no reason he won't be live a very, very normal and happy life. So we're just so excited for 3D printing. We're so grateful for all of you that are so interested in it and have dedicated your lives to it. And we're eternally grateful. Something you can never pay back is to save your child's life. So thank you to all of you.
Thank you very much to both of you. Thank you very much to both of you for being willing to come on Skype today and share your thoughts. We have a little bit of a technical difficulty on our end, but we got most of what you were saying. So thank you again so much. It's wonderful to see all of you. You look wonderful. You're doing great. Thank you.
Thank you to the Petersons, and thank you to both of our doctors here. Just a wonderful, wonderful example of the life-changing possibilities of 3D and 4D manufacturing. So we have time for a few questions. If you would entertain these for us. A couple quick questions, and I think one that might be really important. You've got the whole industry here in front of you. Tell us what you need for us to help you make more stories like this possible. What technology gaps are apparent to you that could be filled?
Yeah, I can pipe in. One of the biggest things I think many in the audience realize this is really for us to be able to expand the range of biomaterials that we can print with. I mean, polycaprolactone works really great for this application for the splint. But obviously, and people are doing a lot with metals for implants, but being able to print a much broader range of soft materials for these types of reconstruction purposes would be great.
I echo Dr. Hollister's thoughts. Biomaterial development is going to be very important, and having the ideal biomaterial choice for a specific device application. I also just think partnership with industry is so important. Academic medicine works at a certain pace, and it's not exactly a rapid pace. It's the limitation of the world that we live in. And the work we've been able to do, we would not have been able to accomplish without willingness from industry to help us and assist us through the process.
Great. Do you have some willing partners out there? I think we have a lot more after this presentation. Fantastic. Another quick question from our audience here. Can you speak on any other potential conditions or different things that you're looking at that might benefit from a similar type of process development?
I can speak outside of the field of otolaryngology. Well, within otolaryngology, working with another of Dr. Morrison's colleague, Dr. David Zoft. He's doing work on ear reconstruction for microtia with 3D printed ear scaffolds. We're looking at the use of this technology as a way to help treat esophageal atresia for children who are born with large gaps in their esophagus, to both as an adjunct for the surgery, as well as to use as a platform to try to regenerate tissues. We've used it for a variety of skeletal applications as well as the face and reconstruction. So in my mind, it's like a palette, right? The more colors you have to paint with, the more things you can address, basically.
I totally agree. The tissue engineering field of additive manufacturing is very exciting, and I think has the most transformative promise, but also has the biggest barriers. The advantage, this all started as a conversation, right? We had a condition that we didn't have a good treatment for, and what started as an idea very rapidly could become a real medical device. And there's a variety of different anatomic patient-specific conditions that could potentially have a similar approach.
That's great. There's a couple questions here that are specific, asking about the material in the splint for the 3D printing. Is there a particular supplier of that material? There was a question on that.
Yeah, we have actually we've published a number of papers. We buy it from a company called Polysciences, and it has to be milled very specially. I think that's one of the tricky things was, and I'm sure people in the audience are well aware when you're trying to adapt something for laser sintering, being able to process that material and mill it into the right particle size is critical.
Quick question too. Let's just fast forward ourselves 3 to 5 years. What do you see happening in the near future in this field?
I foresee that this field is difficult because of, especially in pediatrics, because of the low volume of patients, and I think it's even for large medical device companies with 3D printing, it's still economically very difficult to address these markets somehow. I think from a business model standpoint, I think you'll see a lot more sort of academic industrial partnerships where you might even have more 3D printing centers that make very specialized implants locally at academic medical centers and hospitals. You know, there's going to be a mix of where you 3D print maybe 10,000 implants a year and print maybe 3 implants for specific conditions. I think that will happen in the future. I think, as Bobby said, we're going to see more of a fusion of tissue engineering and 3D printing. We're going to be able to print tissue analogs to test 3D tissue models to test drugs in the culture. You'll see a much broader expansion of 3D printing as it is now for surgical planning and simulation. And I think we'll see more integration of cell printing and material printing to make tissue engineered constructs.
Yeah, I definitely echo those thoughts. I'm very excited. I think this is a very kind of critical time for the fusion of additive manufacturing in the medical field. The basic science of additive is very, very robust, and there's people with 20 years of experience in the field that know their technology and their devices and their machines very, very well. And what I've seen even in the 5 years that I've been in the field is there hasn't been the same buy-in or contribution on the clinical side. And as this technology is propagated and more people are becoming aware of it, you're seeing a lot more clinicians that are coming up and saying, hey, I have an idea about a potential application for this. Can we talk about a collaboration? And I think that's going to be critical because we have wonderful engineers and scientists who know what they can do, but they just need someone to tell them how they can use it to treat a clinical condition. So I think within the next 5 years, you're going to really see an explosion also of clinicians that are involved in the field that are coming to the table with very bright and innovative ideas.
That's awesome. And, you know, this is all about collaboration, right? So we're very pleased that our doctors here can stick around a little bit after this session. If you have specific questions for them you'd like to ask, or maybe a potential idea for collaboration, we welcome that as well. Please join me in thanking our doctors here and their presentation. And I also have to add, as a proud alumni of the University of Michigan, makes me super proud. So a little go blue out there from somebody maybe. But thanks so much for joining us this morning. This was really a transformational experience this morning. So glad to see Garrett there live and doing well and thriving and growing, and just, you know, the real payoff at the end for all this research and development and hard work that we do every day. So thank you very much. We have a token of appreciation for our speakers. And also, if you'd like to join us, we're going to, in case you missed the opening video yesterday, we're going to be showing that again. If you're interested in learning more about the adaptation of medical devices in 3D and 4D printing, we have an entire conference track on that. You'll want to check our conference proceedings and see how you can get involved in that. On behalf of SME, thank you very much.